Hi everyone. As Ruth mentioned, I'm going to speak to you a little bit about a study that we did with the Chinese women with breast cancer, what their challenges are, their coping strategies and supportive care needs. I am here on behalf of myself, Dr. Janelle Levesque and Professor Afa Gerges. So why do we think this research is important, or why do we need it? In 2016, almost 16,000 women were diagnosed with breast cancer, and this has risen to over 17,500 in 2017, with over 3,000 of these estimated to be fatal. Breast cancer diagnoses encompass complex physical, psychological, and healthcare challenges to these women, and these arising stresses also may be exacerbated by culturally and linguistically diverse patients. This can be due to their unfamiliarity with the health system, a lack of appropriate culturally and linguistically appropriate and sensitive information, and the communication barriers they have with their health team, even with the use of interpreters, because that can lead to feeling misunderstood, isolated, and even overwhelmed. So the significance of this research is that we need culturally appropriate resources to assist CALD patients and their caregivers. Our previously developed intervention called Coping Together was evaluated that it may be suitable. So therefore, we thought, since there is a significant need for this, we used the previously developed Coping Together, which is an illness self-management intervention for patients and caregivers, and we thought we'd see if this was potentially suitable for the CALD patient and caregiver groups. However, we do need to point out that any adaptation must occur within the context of consumer consultation to ensure that we kind of hit the nail on the head and find out what this particular culture wants and what they need, and that way we can address all of these types of issues. We have a need in the English population and even more so in the CALD population. So we wanted to know if Coping Together was relevant and what needs to change in order to make it relevant for, in particular, Chinese women with breast cancer, and understand the information required to achieve a suitable level of self-management skills. So our methodology encompassed 26 patients who were deemed consenting and eligible, and they were invited to take part in either a semi-structured interview, which went for about 40 to 60 minutes, or a focus group, which went for an average of about 2 hours. They were conducted in the participants' preferred language, so that was either English, Chinese, or Mandarin. And then this data was audio recorded, transcribed, and translated into English. Our recruitment sources were the Liverpool Cancer Therapy Centre, located in southwest Sydney, and also Can Revive, which is a Chinese-specific support organisation for women and other types of cancers. We used thematic analysis to analyse the data, and this consisted of 2 coders, and anything was cross-referenced between another coder. So what did our results show? It showed 5 distinct themes. Our first was social support. This showed the importance of connections with others. For example, telling someone about cancer. Did that affect them? Did that affect me? Who will it affect? For example, one patient said, "I know my mother's character. She would just cry non-stop for a few months. I don't want to do that to her and see how sad she would be, and it would be harmful to her health." The level of disclosure was mixed, with a general tendency to only tell people who needed to know, while protecting others such as the elderly, young children, and even teenagers. All participants did find great value in their involvement with Can Revive to address their need for social support. The next one was information seeking. This was a strong theme and expressed participants' pivotal need for information about cancer and treatment options. Patients wanted to know what options they had if it was just chemo that was available, was radiation available, what did they want to know? But also they did identify that they wanted more information about their personal medical kind of history. Participants recounted seeking information from their medical team unsuccessfully, and therefore they had to go do their own homework by searching the internet, asking friends, reviewing kind of any information that was given to them by their doctor with the aid of a dictionary. So Our third theme was the unreliability of interpreter services, but that was really the language barriers in healthcare settings. This problem was overcoming basically not being able to understand what was said to you, and also not having kind of faith in the interpretation services. While the overall perception of quality of care was very, very high, a number of participants did report that doctors did not answer their questions directly, or they were not able to understand the question directly, and therefore they felt they had limited involvement in their treatment decisions. A patient, for example, said, "My son had to say to the interpreter, 'Sorry, can you stop interpreting, please? We'll speak for ourselves.' He immediately heard that the interpretations were incorrect." So that was kind of a shock to us, and perhaps contrary to what we all think, people still they do pick up on things, and even though we take what doctors say as gospel, especially if they don't understand it, this can kind of lead to a bit of a mixed feelings. So our fourth theme was the psychosocial impact, and this was raised by most participants, who described their experience with cancer as psychological torment, or it was like a disaster. Perhaps contrary to the expectation that Chinese people would not wish to engage in psychological care due to issues such as stigma or taboo, these women recognised the strong need for psychological intervention to assist them with their mood, their negative thinking, and overall feeling better. They also wanted these options to be available in Chinese so they could directly engage with the person they were speaking to. And our last theme was challenges and coping behaviours. This was demonstrated that some of the stresses faced by CALD patients are similar to those experienced by other patients with breast cancer, including side effects, treatment decisions, uncertainty, fear of recurrence, and having just a generally low mood or a general low outlook on life. Coping behaviours did include making dietary changes, using things such as Tai Chi, information-seeking behaviours, and the use of traditional Chinese medicines. Support group attendance was high in this population, as well as social comparison. So what were some of our conclusions? Chinese women and their Anglo-Australian counterparts have similarities, but they also have big differences. Both Chinese women and Anglo-Australian women have the same basic need for information and the need to access psychosocial care. However, differing from their Anglo-Australian counterparts, Chinese women utilise culturally distinct coping behaviours and have different information-seeking behaviours. They interact with the health system very differently than their Anglo-Australian counterparts. So while coping together, the study I mentioned previously has been identified as suitable for CALD populations, it is evident that cultural adaptation does need to be made in order to make it a lot more suitable. There is still a wealth of knowledge and understanding about the CALD population that we do not know. However, I do think that we are taking pretty valuable steps in getting there, and that was that. Thank you.